Good morning, everyone. I am Dr. Noel Al-Asmar. I will be talking about colonic disorder. Concerning our outline, inflammatory bowel disease will be discussed in detail in another lecture. So we'll be focusing about diverticular diseases, irritable bowel syndrome or IBS, and colon cancer. Our learning objectives would be first to define diverticular disease and discuss its clinical presentation, possible complications, and treatment. Second, to define functional gastrointestinal disorders with emphasis on irritable bowel syndrome or IBS, to discuss the approach to diagnosis and treatment of IBS, including psychological treatment and pharmacological treatment, with the drugs that are usually used to decrease symptomatology in IBS, including anticholinergics, antispasmodics, antiflatulents, antidiuretic, antidepressant, and other approved treatments. And finally, to discuss the epidemiology, risk factors, signs and symptoms of colonic cancer, means of diagnosis of colonic cancer, and of management of colonic polyps. So, we'll start with diverticular disease or diverticulosis. We can have diverticulosis anywhere in any hollow organ, but colonic diverticulosis is the most common, and it is defined by the presence of outpouchings or herniations of colonic mucosa and submucosa through weak spots in the muscular layer of the colonic wall. And this is the endoscopic aspect of colonic diverticulosis. So as we can see on the left side of the screen, we have a drawing with the layers of a normal intestinal wall, mucosa, submucosa, muscle, and serosa. And as we can see, we have protrusion of all the layers throughout the intestinal wall. This is what we call a true diverticulum. An example is Meckel's diverticulum. And on the extreme right side of the screen, we can see an example of a false or pseudo diverticulum. As we can see, only the mucosa and the submucosa are protruding through a weak point of the muscular layer, and these are usually the diverticula we see in the colon, or what we call colon tics. So as already said, diverticulosis can occur anywhere in any hollow organ, such as the small intestine and the stomach, but the colon remains the most frequent site of diverticulosis. So diverticulosis occur most frequently in the colon and predominantly in the sigmoid colon, because it is thought that this is where we have the higher pressure due to the anatomy of the sigmoid colon from intraluminal stools. So it is mostly affected, but we can know that the entire colon can be affected, and in the Asian population, the right-sided distribution is more common. As we said, that high luminal pressure is believed to cause mucosal protrusion of mucosa and submucosa through weak areas of the colonic wall, and specifically at the point where the vasa recta penetrate the bowel wall. So at these specific areas, the high pressure will cause the protrusion of the mucosa and the submucosa, and this is how diverticula will form in the colon. So if diverticulosis affects mostly the colon and predominantly the sigmoid colon, what are the risk factors for development of diverticular disease? It is thought that it mostly affects industrialized or Western populations secondary to their diet habits. The well-known risk factors are increasing age, mostly patients more than 50 years, obesity, especially in young males. So young obese males are at risk for diverticular disease. Patients with constipation, those who consume a low-fiber diet and have heavy meat consumption, those with a connective tissue disorder such as Marfan and Ehlers-Danlos, and there's a genetic predisposition. That's why we can find diverticular disease in different family members. In Western societies, this condition is uncommon in patients less than 40 years. 10% of patients more than 45 years will have diverticulosis, and 80% of those more than 80 years will have diverticulosis. So it's related to age, mainly to specific population with specific diet habits, with all the other risk factors already mentioned. Although diverticulosis is a benign condition, several problems related to diverticulosis may arise. So a patient who has these outpouchings or these diverticula can encounter in up to 20 to 25% of the cases what we call diverticulitis, which is inflammation or infection of one or more diverticula. Diverticulitis can be an uncomplicated diverticulitis, very simple case, and it can be a complicated diverticulitis. It means it can be complicated by a perforation with formation of an adjacent abscess, or a perforation with more diffuse infection with what we call peritonitis, and this infection can progress to adjacent organs and cause fistula into the vagina or the bladder. The second complication of or manifestation of a diverticular disease would be bleeding. And bleeding from diverticulosis is one of the most common causes of lower GI bleed in adults. Just to know that diverticulitis occur mostly in left-sided in sigmoid diverticulosis, and bleeding usually occurs from right-sided diverticulosis. But of course, we can bleed from left-sided colonic diverticulosis. And a third manifestation of diverticular disease, aside diverticulitis and bleeding, would be painful diverticular disease, which means patients with diverticulosis will have abdominal pain with alteration in bowel movements without any other explanation for that pain, without acute diverticulitis, and this is thought to be part of the irritable bowel syndrome or IBS. So, these are some ways where and how we can find diverticulosis. Usually it's a painless condition. It causes no symptoms in the majority of the cases, and most of the time it's an incidental finding. If we're doing a colonoscopy for another reason or a screening colonoscopy, we can find these diverticula, as you can see in the image. If we are doing a CT scan or any imaging for any other condition, we can find these diverticula throughout the colon. So concerning the first manifestation of diverticular disease, which is diverticulitis, it occurs in up to 25% of the patients with diverticulosis. It's inflammation or infection of the diverticulum. It is usually caused when the neck of the diverticulum is obstructed, usually by a fecalith, and it distends, leads to bacterial overgrowth, infection, and possible microperforation, which usually occurs in almost all cases of acute diverticulitis, or macroperforation, which leads to abscess formation or peritonitis or fistulas into adjacent organs. So what are possible complications of a diverticulitis? As we know, it commonly occurs in the sigmoid colon, and it can rupture, cause a perforation that could be limited to the region around the sigmoid, causing an abscess formation, or if the perforation is not contained, it can cause generalized peritonitis. This occurs more commonly in the elderly population and immunosuppressed patients. Moreover, due to intra-abdominal sepsis, we can have cases of pilophlebitis, which is portal vein thrombophlebitis. These patients may develop jaundice and hepatic abscesses, and this condition has a high morbidity and mortality. Also, we can have colovesical and less frequently colovaginal and colocutaneous fistulas when the inflammation and the infection is not just localized to the sigmoid but extend to the adjacent organs. On the long term, repeated episodes of diverticulitis can cause chronic inflammation in the sigmoid colon and cause a condition we call smoldering diverticulitis, causing a colonic obstruction. So what are the clinical features of a patient presenting with diverticulitis? Usually they present with low left quadrant pain that may radiate to the flank, to the back, or suprapubic region. They might have fever, alteration of bowel habits, more commonly constipation, anorexia, fatigue, less commonly nausea, vomiting, and sometimes urinary symptoms. It's not common to have a bleed associated with diverticulitis, and on physical exam we have left lower quadrant tenderness, sometimes we have localized guarding, and if there is a free perforation with abscess or peritonitis, rebound tenderness occurs. What do we have on labs and imaging? So leukocytosis occurs in the big majority of the cases, around 80%. When diverticulitis is adjacent to the bladder, pyuria occurs, which is present of leukocytes in urine samples. Ultrasonography may show inflammation. As we know, ultrasonography is operator dependent, and sometimes abdominal tenderness may preclude from applying sufficient pressure to examine the involved colonic region. Enema studies help to identify diverticulosis but not diverticulitis, and they are not recommended in acute diverticulitis secondary to the risk of perforation with insufflation. The preferred diagnostic method to confirm the diagnosis and to look for any complications when abscess or peritonitis are suspected, it is the CT scan. Up to 20% of CT scans may be negative in the setting of acute diverticulitis. These are false negative results. So we should stick to the clinical suspicion in patients with diverticulosis and specific symptoms and treat accordingly. What is important to note is that colonoscopy is contraindicated during an episode of acute diverticulitis due to the high risk of perforation. After acute syndrome resolves, the patient should have a colonoscopy to exclude an underlying malignancy. We should usually wait 4 to 6 weeks before performing a colonoscopy after an episode of acute diverticulitis. And when there is a complication, we should wait more, around 8 weeks. What about treatment of acute diverticulitis? When it is a mild, uncomplicated attack, as confirmed by a CT scan, the patient could be treated as an outpatient with broad-spectrum antibiotics for gram-negative and anaerobes with cipro and flagyl, ciprofloxacin and metronidazole for 7 to 10 days. Patients are started on a clear liquid diet, and then we advance the diet as tolerated. Once the condition resolves, after 4 to 6 weeks, colonoscopy should be done to rule out colon cancer, as already mentioned. If patients are unable to tolerate PO intake, or if they do not improve with the above, or if they are initially diagnosed with complicated diverticulitis, with an abscess or peritonitis, or elderly patient or immunosuppressed, they should be hospitalized for treatment, kept NPO, started on broad-spectrum IV antibiotics. The CT scan that already has been done initially to rule out abscess or perforation. In case of perforation with peritonitis, it's an emergent surgery that should be done. In case of an abscess formation, if the abscess is less than 4 centimeters in size, we should start the IV antibiotics and the conservative management, observe the patient. If he improves with this management, if the abscess is more than 4 centimeters in size, usually we should intervene to drain it because IV antibiotics would not be enough alone. So we usually do a CT-guided percutaneous drainage for this abscess if it is accessible to interventional radiology, and if not, we drain it surgically. And when we have a complicated diverticulitis, if the acute episode resolves with the antibiotics plus or minus drainage, usually we should do a surgery later on, short after doing a colonoscopy. And it is important to re-emphasize on these 2 points. So, a surgery, we have emergency surgery and elective surgery. Emergency surgery is done, as mentioned, when we have on presentation peritonitis or a secondary peritonitis, when we have an uncontrolled sepsis. If we have a big abscess that is not accessible to CT drainage, or an ongoing sepsis with a clinical deterioration, we should go for emergency surgery. In all other cases, when we have a complicated diverticulitis, when we have a fistula, when we have a stricture due to recurrent diverticulitis, or when we just have recurrent diverticulitis in a young patient, then we opt for elective surgery after the acute episode resolves. Concerning the prognosis, most patients improve over 2 to 3 days. For those who do not improve or who have secondary complications, they should be managed accordingly. When we have a first episode of acute diverticulitis, risk for a second attack is 25%. And after a second attack, risk for subsequent episodes is more than 50%, and the risk increases with the subsequent episodes. We used to say that after 2 episodes of diverticulitis, surgery is recommended to remove the segment of colon. But now we have new recommendations that do not stick really to the number of episodes, that treat and according to each patient, to his age, his comorbidities, impairment of quality of life, and the frequency of recurrence of diverticulitis. And based on each case and on the discussion between the surgeon and the patient, decision is taken. So diverticulitis was the first clinical presentation or complication of diverticular disease. A separate complication of diverticulosis is diverticular bleeding. Diverticular bleeding is not related to diverticulitis, and as already mentioned, bleed and diverticulitis can occur in any diverticulum throughout the colon, but it's usually known that the left-sided and sigmoid diverticulosis usually got infected, and the ones on the right side have tendency to bleed. If acute diverticulitis causes pain, bleed from diverticulosis cause an acute painless lower GI bleeding. Usually these bleeds are self-limiting. A colonoscopy is performed, especially if this patient did not have any previous colonoscopy, to rule out other causes of GI bleed, and sometimes for ongoing bleeding for therapeutic purposes. If the patient had recent colonoscopy and has no other potential colonic pathology and he's stable, then we can wait for symptoms to self-resolve. If they do not resolve, then we could consider colonoscopy to try to identify the diverticular reticulum that is bleeding to treat it, versus we can go directly to interventional radiology in case of ongoing bleed and unstable patient. After diverticular disease, we move to the other chapter on our outline, which is the irritable bowel syndrome, or IBS. IBS is a gastrointestinal syndrome characterized by chronic abdominal pain and change in bowel habits in the absence of any organic cause. It's the most commonly diagnosed GI condition, is one of the most frequent, if not the most frequent, functional disorder, and a very common cause of daily GI consultations. Irritable bowel syndrome is diagnosed based on Rome 4 criteria, which includes, first of all, recurrent abdominal pain or discomfort for at least 1 day per week in the last 3 months, which is associated with 2 or more of the following: pain related to defecation, which is increasing or improving pain after defecation. Second, it's associated with a change in stool frequency. And third, it could be associated with a change in stool form or appearance. So females are diagnosed more than twice as often as males with this condition. As we know, symptoms of IBS often correlate with episodes of psychological stress, and it could be associated with other conditions such as depression, anxiety, fibromyalgia. There are 4 subtypes of IBS. The first subtype is IBS with predominant constipation. The second subtype, IBS with diarrhea. It's usually associated with increase in circulating serotonin. The third subtype is mixed IBS with both diarrhea and constipation. And the fourth subtype is unclassified IBS. These patients can have normal bowel movements. As mentioned, there are criteria to diagnose IBS, but what we should keep in mind is that IBS patients are the ones who do not have any organic disease, so should not have red flags. Almost 50% of IBS patients have mucus with stools, but they should not have bloody stools, large volume diarrhea, nocturnal symptoms and diarrhea and abdominal pain during night, greasy stools, weight loss, anemia or any other blood work abnormalities such as high ESR or CRP or electrolyte disturbances, or any stool abnormalities such as high fecal calprotectin and positive FIT test. So after saying that, we have to look for red flags to exclude a more serious illness and to do the necessary investigations for that. If these were excluded, then the diagnosis of IBS can be based on typical clinical findings as mentioned with the Rome criteria. Treatment of IBS consists first of all on counseling patients, educating and reassuring them. Although it's a benign condition, they should know that it's a chronic condition. They should learn how to deal with it and understand their disease. We can first advise on a dietary modification. Low FODMAP diet has proven to be beneficial. FODMAP are fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. These are short-chain carbohydrates that are poorly absorbed and are osmotically active in the intestinal lumen, where they are fermented, causing bloating and pain in patients with IBS and and visceral hypersensitivity. So we should advise them to stick to low FODMAP diet. Also, they can avoid gas-producing foods, and in some cases, we can advise on avoiding wheat and lactose. Other than dietary modification, these people can benefit from physical activity, as this can lower their generalized stress and anxiety and help to improve the IBS symptoms. As we can know also in the pathophysiology of IBS, they might have dysbiosis, so alteration in their intestinal flora and microbiota. That's why probiotics can be beneficial, and rifaximin also, that is a locally acting antibiotics that is not absorbed into the GI tract and works inside the intestinal lumen. Rifaximin can be beneficial in IBS diarrhea patient or unclassified type, especially with bloating. Patients with abdominal pain, antispasmodics are prescribed, and those with IBS constipation, laxatives are prescribed, and diarrhea, antidiarrheal agents. And in cases where all these strategies do not seem to be very beneficial, we can move to anxiolytics and antidepressants, especially when these patients have generalized anxiety disorder or underlying depression with other symptoms and other systems as well. We move to colorectal cancer. This is the third most common cancer in the US and the second leading cause of death from cancer. Lifetime risk for an average patient is one colorectal cancer in every 18 to 20 patients. The mean age for diagnosis is 73 years. 10% of the cases occur in patients younger than 50 years of age. Overall incidence and mortality has been decreasing, but the incidence in young patients has been increasing. Men develop colorectal cancer 5 to 10 years earlier than women, and African American also develop it 5 to 10 years earlier than whites. Other than age, sex, and ethnicity, other factors play a role in colorectal cancer. We have environmental factors. That's why we have a geographic variation in colorectal cancer distribution. The majority of colorectal cancers, around 96–98%, are adenocarcinomas that derive from colonic glandular epithelium. They are mostly located in the sigmoid colon, and on presentation, colonic adenocarcinomas are mostly localized to the colon or with regional involvement, which means positive lymph nodes. The remainder of colorectal cancers include neuroendocrine cancers with a variety of histologies ranging from well-differentiated to high-grade carcinomas. True carcinoids are the second most common histologic colorectal subtype. Other than neuroendocrine cancers, we can have epidermoid carcinomas. We can have lymphomas in the colon, just like lymphomas elsewhere in the GI tract. Lymphomas of the GI tract are mostly B-cell lymphomas. Primary colorectal lymphomas are rare. They account about 10 to 20% of all GI lymphomas, but colon lymphomas are less than 1% of colorectal cancers. Other than that, we can have very rare sarcomas and GIST, which are gastrointestinal stromal tumors, which are submucosal lesions. They are mostly located in the stomach, but also we can have few cases in the colon. Concerning colorectal cancer risk factors, as already mentioned, age is the main risk factor, gender, with the males more frequent than the females, race, African American, also IBD and not IBS, inflammatory bowel disease such as ulcerative colitis and Crohn's disease with colonic involvement. We have family history. We have some defined inherited syndromes that account for only a small percentage of colorectal cancer, as the most common cancers are sporadic. We have acromegaly. We have other risk factors such as obesity, low physical activity, smoking, excessive alcohol intake, high fat diet, and low dietary fiber. And we should keep in mind that patients with Streptococcus bovis, bacteremia, or endocarditis, they should have a colonoscopy to screen for a big polyp or a tumor. That is usually the port of entry of such a bacteria into the bloodstream. So now we'll go into details in each risk factor. So concerning patients with IBD who are at risk for colorectal cancer, we have the ulcerative colitis and the Crohn's disease with a colonic involvement. The risk is related to duration of disease, usually more than 8 years, and extent or amount of colonic involvement or inflammation. It's usually when we have an extension beyond the splenic flexure. The risk also increases in patients with concomitant PSC, which is primary sclerosing cholangitis. Patients with ulcerative colitis have a 10 to 20 times the risk of the general population to develop a colorectal cancer. Patients with Crohn's disease with a colonic involvement, more than 1/3 of the colon, have 6 to 8-fold risk of developing a colorectal cancer. So these patients with IBD have special surveillance guidelines for screening for dysplasia and colorectal cancer. Then we have a family history, positive history. For patients with a first-degree relatives with colorectal cancer, they have 2 to 3-fold increased risk of colorectal cancer. When they have 2 first-degree relatives, they have 5 to 6-fold increased risk. When there's a first-degree relative with adenoma, they have 1.8-fold increased risk of colorectal cancer. And when this first-degree relative with adenoma is less than 60 years of age, the risk is 2.6-fold. What about some defined inherited syndromes that account for only a small percentage of colorectal cancer? So concerning the inherited syndromes or polyposis syndromes, there have been several dominant and recessive genetic conditions that have been identified and known to convey an increased risk of colorectal cancer. So what are these inherited polyposis syndromes? We have the familial adenomatous polyposis or FAP. It is due to a genetic mutation on the APC gene on chromosome 5. These patients have multiple adenomas in the colon, more than 100 lesions, and they might have also adenomas of the duodenum. The age of onset of cancer is usually around age of 16, but these patients should have a colonoscopy around age 10 to 12 to look for these adenomatous lesions in the colon. And if present, the risk of colon cancer is 100%, so they should have a colectomy. And if any colonic adenoma is found, or at age 25, whichever comes first, they should have also an upper GI endoscopy to look for any lesions in the duodenum. Another syndrome is hereditary non-polyposis colon cancer, or what is known by Lynch syndrome. There's a mutation at the mismatch repair genes, and these patients have adenomas of the colon that give a high risk of colon cancer in 30% of the cases. Age of onset of cancer is at age 40, and these patients should be screened with a colonoscopy starting age of 20 to 25 years of age. Lynch syndrome may have tumors in other organs such as the ovary, the uterus, the kidneys, pancreas, and the stomach. We have another form of attenuated polyposis, which is called MUTYH-associated polyposis or MAP. These patients have adenomas of the large intestine and duodenum, mutation of the MYH gene, age of onset of cancer around 45 to 50 years, with a risk of colon cancer of 75% in average. Other syndromes, Peutz-Jeghers syndrome with the polyp type hamartoma, which might appear in the large and small intestine in the first decade of life, slightly above average risk of cancer, STK11 gene mutation. These patients have also associated lesions such as oropharyngeal melanin pigment spots and other tumors. The juvenile polyposis, also the polyp histology is hamartoma, rarely adenoma. So the adenomas are found in FAP, MAP, and Lynch syndrome, and in Peutz-Jeghers and juvenile polyposis, there are hamartomas. In the large and small intestine, also first decade of life, 9% average risk cancer of colon cancer, and there are multiple mutations that could be incriminated. As already seen, colonic cancers arise from the generated colonic polyps. So what are colonic polyps? A polyp is a proliferation of epithelial cells that protrudes from the mucosal surface into the lumen of the intestine. A polyp may be pedunculated, as the first image on the left, A, with a stalk. It can be a sessile polyp, which means it's a grossly visible mass without a stalk, like in B. And it can be flat, completely flat, like in C. Polyps are either non-neoplastic or neoplastic, like adenomas. Neoplastic polyps have the potential to become malignant. Polyps may sometimes cause bleeding, prolapse, or obstruction of the intestinal lumen. Grossly, colonic polyps can be divided into adenomatous polyps and non-adenomatous polyps. Non-adenomatous polyps account for 90% of all colonic polyps. They are found in more than half of the patients older than 60 years of age. They can be subcategorized into hyperplastic, inflammatory polyps such as in IBD patients, lymphoid, and juvenile polyps. Hyperplastic polyps are usually small, found in distal sigmoid colon and rectum. They are not malignant and not associated with increase in malignant potential. Juvenile polyps, called hamartomas, develop in the rectum of children in their first decade. They can be part of a juvenile polyposis or Peutz-Jeghers syndromes, and in these cases that they increase risk for colon cancer. We can find also juvenile polyps as solitary polyps in young patients. Adenomatous polyps, such as their names show, are adenomas. And adenomas have a malignant potential. There are neoplastic polyps that will evolve into a cancer if left and untreated. Adenomas by themselves are benign. They can exhibit low or high-grade dysplasia when examined under the microscope, and they have an anatomical distribution that parallels that of colorectal cancer. They can be sessile, flat, or pedunculated, as already seen. They have a range of sizes. They can bleed. And the most important risk is that they are a precursor to colorectal adenocarcinoma. And this process occurs according to adenoma-carcinoma sequence. Adenoma, then low-grade dysplasia, high-grade dysplasia, and then carcinoma. That's why these lesions should be resected in order to decrease the risk of colorectal cancer. What is an advanced adenoma? An advanced colonic adenoma is an adenoma that measures 1 centimeter or more, that has anivellous histology or high-grade dysplasia component. When we are doing a colonoscopy for a patient and resect polyps, and we find that they have at least one advanced adenoma, or they have 3 or more adenomas, they are at greater risk for synchronous, which means to develop simultaneously, or metachronous, for developing after a time interval a colorectal cancer. So these patients with an advanced adenoma or multiple adenomas should have a repeat colonoscopy in a 3 years interval. Concerning the screening modalities available for colorectal cancer, we have the tests that detect adenomatous polyps or cancer. We have the colonoscopy that should be repeated every 10 years if it's complete colonoscopy with a good or excellent preparation, with no polyps found, with no personal or family history of polyps or cancer. We have the flexible sigmoidoscopy every 5 years, the CT colography every 5 years, the double contrast barium enema every 5 years. To know that these last 3 tests should be combined to other stool tests, the high sensitivity GAIAC-based fecal occult blood test, annually, to be done annually, the fecal immunochemical test or FIT test also annually, and the stool DNA with an uncertain interval. To note that screening should start at age 45 years for average risk patients as per the new American guidelines. The age was before 50 years of age, and now it is 45 years of age. Just to know that patients with a high risk, those with IBD, with a family history of adenomatous polyps or cancers, those with any familial inherited polyposis syndromes, should start screening at younger age, to be determined depending on each case. Thank you for listening. Any questions?